10-minute revision of GIT hepatobiliary system. I'll only study the topics I have highlighted. Okay, so BER, highest for duodenum, maximum for duodenum, because duodenum maximum concentration of interstitial cells of Cajal is in pylorus, and duodenum is close to pylorus, so maximum BER in duodenum and minimum BER in cecum. I'm remembering it as the ileocecal valve will inhibit the whole rhythm. Then enterogastric reflex, where the intestine inhibit the gastric emptying, because नहीं तो आप खाते ही जाओगे. So it's like Bain bridge reflex for heart and J reflex for lung and enterogastric reflex for GI. So it's shown by CCK secretin and peptide Y. CCK secretin and peptide Y. CCK and secretin, other functions of CCK are pancreatic enzyme जो है वो secretion increase करेगा, GB contraction increase करेगा, GI emptying it will decrease, and sphincter of Oddi relaxation it will increase. So intestine के आने के बाद जो जो secretions होगा वो उसको increase करेगा, वो and sphincter of Oddi को relax करेगा ताकि pancreatic जो भी secretions है वो अच्छे से हो पाए, लेकिन वो gastric emptying को inhibit कर देगा. Enterogastric reflex. Secretin also same action as ICCK, and yes, okay. Then next, first, so this is first arch to, this is from gastroileal reflex, gastrocolic and gastroileal reflex. So these are more in children. Right after eating they want to pass feces. So the first urge to defecate is at 18 millimeter mercury, involuntary defecation 55 millimeter mercury, and similarly I have just written down here so that we can revise together. The first urge to void is at 150 millimeter mercury, and marked sense of fullness, and maturation at 400 millimeter mercury. So for urination it is 150 and 400. For stool passing it is 18 and 55. And then radioactive intestinal peptide has this syndrome, WDHS syndrome. WDHS syndrome, first we'll see its function. It increases water and electrolyte secretion and increases relaxation of smooth muscle and sphincter. Okay, so it promote peristalsis. It pushed the fluid to the distal parts, and so it causes, obviously secretions are also more, so it causes WDHS syndrome, which is watery diarrhea, hypokalemia, and eclarohydria because VIP also inhibit HCl secretion. Okay, then gastric acid secretion is under the influence of gastrin, G cell, enterocorphin like cell which secrete histamine, and vagus nerve which secrete acetylcholine. Okay, and then these are all the cells in proximal to distal order. So in fundus we have enterocorphin like cell which secrete histamine. In this is greater curvature. In greater curvature we have parietal cell or oxyntic cell. It is the same cell, parietal cell or oxyntic cell, which obviously secrete hydrochloric acid and intrinsic factor. Then greater curvature, another cell, chief cell which secretes pepsinogen. Another cell in greater curvature, G cell, which obviously secrete gastrin. Another cell in G cell which is mucus cell which secrete mucin. Okay, then from pre-pylorus, D cell secretes somatostatin. Duodenum, K cell secrete enchidin. S cell secretes secretin. I cell secrete ICCK in second part of duodenum. Okay, so first we will see enterocorphin like cell, then we will see parietal cell, oxyntic cell, then we will see chief cell, then G cell, then mucus cell, then D cell, and K cell, then S cell, then I cell. Then this is the salivary secretion process. Maximum concentration is to colon, maximum concentration and maximum amount is in saliva, and lowest sodium concentration in GIT is in saliva, because so saliva gets reabsorbed. But towards the end, when flow increases, sodium cannot get reabsorbed, so concentration as flow increases, concentration of saliva decreases, because it is unable to get reabsorbed with high flow. So in saliva its concentration increases. This is a different, don't add this concept to this fact. This is a separate isolated fact that low sodium concentration, minimum sodium concentration in GIT is in saliva. This is for the stomach secretion because HCl is more. This is pancreatic secretion because bicarbonate is more. Easy stuff. And then GI pharmacology. Okay, so side effect of PPI, it will cause Clostridium difficile infection, it will cause pernicious, it will cause gastric atrophy, pernicious anemia, vitamin B12 deficiency, it will cause fracture risk, and allergic intestinal nephritis and pneumonia. Some correlations: vitamin B12 deficiency also shown by metformin and nitrous oxide, fracture risk also shown by phenytoin and gliflozin, triple therapy CAP, clarithromycin, amoxiclav and PPI. And then this is drugs for constipation, chloride, and I keep forgetting these drugs. Chloride channel activators is lubiprostone. Guanylate cyclase agonist, CFTR agonist is, I think, linaclotide. Yes, linaclotide, plicanatide. 5-HT4 agonist is prucalopride, and NHC3 inhibitor is tinapenor. Okay. Then vomiting. Drug for seasickness is meclizine and pelanocetrone. Longest, most potent. And side effect of cetrons: headache, QT prolongation and constipation. And pelanocetrone is the only drug that do not show QT prolongation. And cannabinoid, CB1 is essentially cannabinoid, so it causes side effects: red eye and hypertension. Then SAG. So I was confused why RCM and restrictive cardiomyopathy and constrictive pericarditis are considered in portal hypertension, that is high SAG. So I read upon it. So there is liver, there post sinusoidal portal hypertension because of restrictive cardiomyopathy and constrictive pericarditis. So it leads to portal hypertension, post sinusoidal portal hypertension. Then spontaneous bacterial peritonitis, WBC more than 250 per millimeter cube. And this is a fact. Okay. Then this is important: chronic diarrhea investigation. So first we will see the stool osmotic gap, and the formula for stool osmotic gap is 290 minus 2 into stool sodium plus stool potassium. 290 minus 2 into stool sodium plus stool potassium. Okay, so if it is less than 50, that is osmotic gap is less than 50 is secretory diarrhea, because the electrolytes are also secretory, and in osmotic gap it is more than 50, because osmotic diarrhea mostly water is getting secreted, and because water getting secreted because of the food. So in fasting it is osmotic gap resolve, and secretory diarrhea does not resolve. So secretory diarrhea, it can be Zollinger-Ellison syndrome or carcinoid syndrome, and they can be differentiated by this test: no gastric decompression. Okay, if gastric it resolve on gastric decompression, then it is Zollinger-Ellison syndrome. Zollinger-Ellison syndrome resolve on decompression, and carcinoid tumor does not resolve on decompression. Then in positive hydrogen breath test, if it is positive in lactose intolerance, because lactose, if cannot get digested, then it is fermented by bacteria and it produces H+, so it gives positive hydrogen breath test. And then now, if stool fat is more than 7%, then it either can be a mucosa defect where it is not getting absorbed, or it can be a pancreas defect. So we what differentiate pancreas from the intestine? There is no relation between absorption of carbohydrate and pancreas. So D-xylose test will be normal in pancreas defect and will be abnormal if there is a mucosal defect. So if D-xylose is a pancreatitis, then we will do mucosal biopsy, and we will get celiac disease, Treponema whipple, or okay. Then D-xylose test is abnormal. It can be SIBO, or it can be celiac diseases, Whipple disease, etc. So etc. So for in SIBO, it is differentiated by if rifaximin, giving rifaximin. If improves on rifaximin, then it is SIBO or BOGS. Polyp. Okay, notice polyp. This I know. Most common cancer associated with Buerger polyp is pancreatic cancer. It is 100% more risk in people with Buerger polyp of pancreatic cancer. Then polyp. These are polyp cancer. These are non-polyposis colonic cancer. Polyposis colonic cancer are FAP and MAP. In FAP, 100% risk of cancer. In MAP, risk of cancer is less, and there are other conditions associated. FAP is associated with Gardner syndrome and Turcot syndrome, and MAP is associated with FAP is associated with Gardner syndrome, Turcot syndrome. Gardner syndrome is associated with soft tissue sarcoma, and Turcot syndrome is associated with medulloblastoma, glioblastoma. Okay, and then MAP is associated with duodenal adenoma, ovarian and bladder cancer. Duodenal adenoma, ovarian and bladder cancer. And then FAP and HNPCC. FAP is mostly left-sided colon cancer, and MAP is right-sided colon cancer. So right-sided colon cancer, there is more bleeding. Left-sided colon cancer, there is obstruction. Then IBD risk marker of IBD are lactoferrin and lactoferrin and fecal calprotectin increased in IBD. Lactoferrin and calprotectin are increased in lactoferrin and calprotectin are increased in IBD. Okay, then treatment of ulcerative colitis, 5-ASA sulfasalazine steroid first we will give 5-ASA sulfasalazine. If not improved, steroid or biological. If not, or total proctocolectomy plus IPAA, which is also done for FAP prophylactically. Time's over. Let's. Okay. And then for Crohn's disease, steroid. First we'll give steroid, and then resolve with treatment. Okay, so which symptoms resolve with treatment? The mnemonic is P. Periarticular arthritis, peripheral arthritis, episcleritis, and erythema nodosum. Then the cirrhosis part is mostly okay. Then Lilly's index is for prognosis of alcoholic hepatitis. Yes, prognostic index of alcoholic. Madrid score, there is this formula which to see if steroid will be beneficial or not. If less than 32 steroid is given, no, if less than 32 non-severe disease, Madrid discriminating factor is less than 32, steroid not needed. If more than 32, steroid is needed. If more than 32, steroid is needed. Okay, so the formula is 4.6 into prothrombin time, 4.6 into prothrombin time minus control prothrombin time plus serum bilirubin. 4.6 into prothrombin time minus 4.6 into prothrombin time minus control prothrombin time plus serum bilirubin. 4.6 into prothrombin time minus serum prothrombin time plus serum bilirubin. Prothrombin time 4.6 into Madrid discriminant factor 4.6 into prothrombin time minus control prothrombin time plus the serum bilirubin. 4.6 into prothrombin time minus serum prothrombin time plus total bilirubin. Okay, and then mnemonic. The mnemonic is Samanya antibody. Type 1 for type 1 autoimmune hepatitis. The mnemonic is Samanya antibody. Okay, so the most common antibody for SLE is ANA, right? So and then ANA is the most common means Samanya. So ANA and Samanya SMA1 for type 1. So other ones are LKM1 SLA LC, LKM1 SLA LC. Primary biliary cirrhosis, anti-mitochondrial antibody, and sclerosing cholangitis, P-ANCA and SMA. Then liver disease, Wilson disease. Okay, so the chromosomes I'll actively recall. Wilson disease, chromosome 13, 14 is alpha-1 antitrypsin deficiency. Hemochromatosis, chromosome 6. Okay, I think 64 is chromosome 7. Then hemochromatosis, everything H, hook-shaped metacarpal hypothyroidism, hyperparathyroidism, hook-shaped metacarpal hypothyroidism, hyperparathyroidism. 14. Okay. So done. Thank you.